Welcome. Thank you for coming today. We are going to start today with executive session. But before we do that, I'll ask Senator Prentice to lead us in the Pledge of Allegiance.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Oops. So I would take a motion to enter executive session. Do I have a second? All those in favor say aye.
Aye.
Okay, so we've got a lot of work to do today. We've got a couple hearings scheduled, but we're going to get started. I'll give you a minute.
I don't think that will help. April 24. Look at the bottom.
Right. Yeah. All right, well, all set.
Ready as I'll ever be.
Let's start with Senate Bill 124 relative to continuing care retirement communities. I have a motion. I'll move on to pass.
Second.
We got a second. All those in favor say aye. No, I always do that. Yeah.
Yep,
Thank you.
okay.
Thank you, Sophie. You're right on it. All right, so we got a motion ought to pass. I do have an amendment that was put forward by the department. I spoke with Senator Ricciardi. She's fine with this amendment. You should have it. It's an unofficial amendment at this point.
You want to make it a committee amendment?
Yeah, that's what I would like to do. Yeah, it's thorough. I did take a quick look at it, and I should say it appears to be thorough. It was worked out, as I understand, with the department and with the continuing care communities to clarify some language and bring some more certainty to some of these things.
Is there a,
What's that? Oh, all right. I was looking for Mr. Betancourt. Yeah. Yeah. Are there any questions of the department at this point?
is there a fiscal note on this?
Yeah, why don't you come up? Because I can't hear anything unless you.
Thank you. For the record, Jennifer Smith, Legislative Director for the New Hampshire Insurance Department. So there's no fiscal note attached to this bill. It has no impact to the department, really. Any of the changes that are being suggested, which would be the increased reporting requirements for the communities, that can be handled in-house by our financial examiners already. It's not adding any new additional work to them at all. So, and there should be no additional impact to the communities because this is reporting they're already doing internally anyway. We're now just asking them to report it to us.
Sure. And it looks like it just updates some of the language and brings it up to date. As I recall, in the original testimony, it had been a long time since this had been.
Yes, the
refreshed.
statutes is really needed some modernizing, and we've had some communities that have fallen into these financial troubles where we have really had to come in. We've had very little time to come in and try to help them get into a better place, and we've gotten them there, thankfully. But it gives a much earlier warning system to the department, so to speak, for lack of a better word, so that when these communities are starting to show some trouble, we can say, hey, what's going on here? How can we help? And get them to a much better place. It keeps the residents are aware of what's going on as well. It increases a lot of disclosure to the residents so they know what's going on with the financials to the community. But it allows us to jump in and help and say, let's make sure you're solvent and that the residents don't have any cause for concern here.
Right. Very good. Are there any questions?
Do we need a motion to move the amendment? So moved. Second.
So we got motion and a second on the amendment. All those in favor say aye.
Aye.
Opposed? So we've got a motion ought to pass with amendment. Is there any opposition to the amendment?
I kind of abstained only because I wasn't here to hear.
So 4-0. So on the bill 124 as amended. Any further discussion? All those in favor? Do we have to have another motion on that? We had a motion to, no. Okay, the pending motion is now ought to pass as amended. All right, all those in favor say aye.
Aye.
Opposed? Was that an abstention as well?
No, I'm a yes.
All right, so 5-0. Motion to consent,
So move.
Second.
second. All those in favor and consent?
Aye.
Opposed? I'll take that one out.
Yeah, I had a prime bill.
Prime bill.
Yeah, my last one, I think.
All right.
My last one's today too.
All right. OTPA.
Consent.
Yep. All right. Senator Avard, this is one of your bills, Senate
want
Bill
the pass?
120.
As is.
125, I have a motion ought to pass. Do I have a second?
I'll second for discussion.
All right, we've got a motion and a second, 125. Is there any discussion?
Senator, right.
Oh, Senator Prentice.
Thank you, Chair Rochefort. And so here, and I always appreciate the work of my colleague Senator Avard in trying to make sure that people don't fall through the cracks. But I just, it's rare when the department comes out and opposes something. It feels to me, I mean, there are some worthy additions. I think ADLs is one of them. But it became clear during, going back and reading the hearing report in particular, that some of the questions about who is reviewing these in terms of medical personnel were answered. And I wonder, I mean, at least for me, that they were answered. I think we know that the contractor who's doing this, I think it's called Accentra, they have the medical personnel that do these reviews. And I feel like if the provisions of the contract around performance improvement were enforced in a more timely manner, that may be really advantageous to this process.
Yeah, I don't know. Rumor has it that, oh, sorry. I don't know if Accentra got their contract renewed by the executive council for certain reasons. And I also learned that there was another individual who was basically a double amputee that was just cut off the program as well. You're right, the department doesn't come in and usually oppose a particular piece of legislation, but this has been going on for a while. And I don't like to get emotional, but once in a while I do. So, but I think when, again, even after our discussion, I find that somebody else was basically cut from the rules, if you will. I think if we can send this just as it is, if they want to amend it in the House, they're sending a strong signal that we want this thing to be fixed. That's all I'm asking. I don't know what the House is going to do with this at this point. I'm willing to work with people, but I want to send a strong signal that I want this fixed. Having just learned another individual and Accentra, I might be wrong. I'm on the record, but I don't know if the executive council approved their contract. They did not. That's another red flag to me. So I want this fixed.
May I, Chair?
Absolutely.
I'm sorry.
No, it's kind of like we're having a conversation. I want to make sure that we're all.
Absolutely.
Join in.
I want it fixed too, and they're gonna need to get a new contractor if they're not gonna go with the Centra. I think the provision to enforce performance improvement, that became clear to me during the hearing that that is, I think that that really needs to be done, and the emphasis on solving what are, concerns about interactions between organizations that provide these services and the department are like the bigger question. The addition of some services, making them eligible for reimbursement, I think that that totally makes sense. And I just want to say that I feel that the department, I'm going to look at Mr. Lippman and his group, that with what we ask a lot of them, and they do a good job with all that we ask plus more. At least in my opinion, so I want to give them, I'll support you in this, but I want to recognize that we've got to, they only have a little, we got to help them get through this.
And remember too, that it's going to be going to finance.
Yeah, I do, but I just wanted to bring that up because I feel, Henry and his department work really hard, and there seems to be some disconnect between some of these organizations, at least the one that's come forward, and the department that I'd like to see healed and fixed. And that way, your concerns will be addressed, but I don't want to lose in this the work that is done.
And I'm totally on board with you at this. And I think what this does is, if we pass it as is, it goes to finance and it goes to the House. They're going to look at it. They're going to scrutinize it with a little bit more, probably a lot more eyes, if you will. And I'm willing to work with them.
Yeah, I know you.
And I really am. I think it sends a strong signal. I'm in homes all the time.
Yeah, you are.
I see it. I've done the Meals on Wheels. I clean homes. I see people. I listen to people, and my heart goes out to some people that I don't know how they get by. And then when somebody is incapacitated in some level, and they have to go through, forgive me for the phrase, but for the Department of Bureaucracy, I'm sorry, but there's things to go on, and if you're not well, somebody's not helping you through this process, and you get cut off because you didn't answer the question properly, or you didn't, or somebody, hey, look, I got 15 minutes, can you answer these questions? If that's happening, let's tease that out. Let's figure out a way to make sure that this isn't happening. This isn't an end all by passing it as it is. I will work with the department. I did slam the desk a little bit, but then I found out somebody else was cut off the program. And I get these things like, oh yeah, we're gonna work with you. We're gonna work with you. We're gonna work with you. Well, we were working with them last year. We did a little round table. We had a lot of people sitting there. And I think the intent is good. I understand that. I think they're honest players in this. Just want to light a little teeny fire under
Okay.
the caboose.
All right. I want to talk about that, and good to go. Thank you.
Senator, I had a note here and I just saw it right now. Would you be open to a friendly amendment to clarify something?
It all depends.
All right, here it is. So line 22 through 25 on page 2, it says no applicant who is being assessed for annual redetermination shall be denied eligibility under this section without the individual's primary care physician or nurse practitioner's agreement that the application no longer meets the level of care. Would you be willing to add primary care physician, comma, physician assistant, comma, or nurse practitioner?
Yes.
I would. Yeah.
So, yep. So I would propose a committee amendment. It's on page 2, line 23. And after primary care physician, put comma, physician assistant, comma. Any further discussion on the amendment? Oh, we didn't have one. I'll make the motion.
Second.
Senator Avard made the second that. Any further discussion? All those in favor on the committee amendment, say aye.
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 Any opposed? Okay,
I move ought to pass as amended.
ought to pass as amended. All those in favor, say aye.
Aye.
Opposed?
Consent.
Consent? We've got a motion for consent. I'll second that. All those in favor, say aye.
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 Opposed? Senator Avard, would
I'll
you
take it out. Thank you.
like to
Okay.
take that out? Okay. All right. Well, we're on a roll, Senator. 127.
Move out to pass?
Got a motion ought to pass. Do I have a second? I'll second that.
I believe there's an amendment for 127.
Yes.
You all have that? I think Kate gave us an amendment. I had it. I got so many papers.
You wanna share?
Thank you. We had all the parties agreed, right, Kate, involved with this particular, so that, can you help me through this with the amendment? Can you help talk a little bit about it?
Interesting. She doesn't like talking.
Just want to make sure.
No, I get you.
I didn't talk with all the stakeholders, but Kate had
Kate did,
had
yeah.
done so. And I just want to make sure everybody's comfortable with it, but I'm comfortable with it, but I
I think it's worth going through.
haven't heard anybody contact me about it.
Oh, you got it?
Yeah, I do have,
Okay.
thank you. So this is basically a replace all after the enacting clause, new section, long-term care guardianship.
You're looking for.
Did you went through this, right? Are you comfortable with it? Okay, this was a bill that, we talked about in the past. Were there any hiccups at all on the discussion on the amendment?
Absolutely. If you want to come forward and
Okay. Again, this is for the public guardianship, right?
if you could turn the microphone on and state your name, that would be great.
For the record, I'm Lisa Britt Solsky Stevens, and I'm the CEO at Office of Public Guardian. The amendment that the stakeholders crafted takes the spirit and the intent of the original bill and basically puts it in a different part of the RSA. We are agnostic to where it lives as long as it accomplishes the end goal. And ultimately, I think that that's what we have here. It's a bill that does exactly what we intended to do, but puts it in a place that the department thought was more workable from their perspective to ensure that we can deliver for these poor people who are stuck in hospitals.
Right, and it does free up beds, correct?
Correct.
All right.
Yes,
All right. And the hospital association was part of the conversation, from what I understand?
correct.
Right. Thank you. Appreciate it. And John Williams, I'm all ready to go with it if John's not here, unless there's any objection.
I don't. I think that you mentioned the concern that was brought up at the hearing is where it was living, what RSA it was, and there was some concern that it maybe opened a Pandora's box. But as I read through this, it's clear that it's in another, and it does. I think it does meet the spirit of the hearing and the prime sponsor's stated intentions. So if you're fine with that, I would, we have a motion and a second on the amendment,
I made the motion.
and I'll second that. That's amendment 0621S.
Thank you. I was gonna call you Britt, but I forgot your first name was Lisa.
So on the amendment, I'm going to call the vote on the amendment 2025-0621S. Is there any further questions or comment before I do that? All those in favor say aye.
Aye.
Opposed?
I move out to pass as amended.
We've got a motion ought to pass as amended. Any, we'll call the vote. All those in favor say aye.
Aye.
I second it.
We had a second from the initial motion, which I had seconded.
Oh,
Yep.
and I too.
Yep. So it's 5-0, OTPA, consent.
Consent.
Consent, second.
So Senator Birdsell moved consent, Senator Avard second. All those in favor say aye.
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 Opposed?
I want to thank the committee for given me a second chance at this and allowing this to be,
Would you like to take this one out?
sure.
Did a
All
good
right.
job.
Thank you. I appreciate
You
it.
really did.
Thank the department, and thank you, HHS, and Hospital Association, and Kate. Appreciate it.
And Kate.
Not to be the least. Did I get another one?
Okay, Senator, the third time's the charm here.
135?
I don't have any amendments for this one.
No, I don't see any amendments with it.
About
rate parity.
135.
Yeah, and it is about parity, that is correct.
And nobody opposes it.
Yep. And as Senator Prentice said, nobody opposed it. I'll move on to pass.
I'll second that motion.
So we got a motion and a second. Any further discussion on 135? All those in favor say aye.
Aye.
Opposed?
Consent?
Senator Avard moves consent. I'll second that. All those in favor say aye.
Aye.
Opposed? Senator Avard, you want to take another one out?
May I?
Yeah,
Thank
absolutely.
you. Thank you, committee.
Yes, he did.
I know. Well, I'm out of here. Okay. All right.
All right. Let's go to Senate Bill 136. Are we ready to discuss that? Establishing an uncompensated care assessment fund and committee within the Department of Insurance.
Senator Prentice?
Yes.
Oh, there's an amendment to be considered, but I'm gonna make a motion for re-refer and then speak to it.
Second.
All right, motion to re-refer in a second.
I heard you. But we do have this amendment, so just my understanding is, talking to some of the stakeholders, that we may not be ready. This might not be ready for prime time right now. Or prime time, it's not ready to go. But I agree with the premise of the bill. I understand that it is not ready.
So
Am I?
do we want to, is the amendment to change it to uncompensated mental health? Should we pass it, the amendment, or should we just re-refer the whole thing? Right, so we should go ahead and do that. Oh, it doesn't? All right, so that's good to know.
Still not ready. I'm okay with re-refer, actually.
I'm fine with
Well,
it.
when they start working on it in the summer, then the amendment will be with it, and we'll, even though it won't be, we can't attach it, we'll make sure that whatever amendment comes through, it includes all of that information.
Okay.
We need to. Because I mean, if we keep it just uncompensated health care, it's gonna be astronomical,
Right.
so.
Yeah, that was the, okay.
And was that the amendment you were referring to, the change from healthcare to mental health care? Because I don't have another
I don't either.
amendment on
Yeah,
that.
that's why, it says potential committee amendment.
Okay,
and
that-
I believe,
that's
the mental
yes.
health piece was what
Yes.
we had talked
Yep.
about. I don't have either sponsor here or the stakeholder.
They're basically all, everywhere it was marked uncompensated care, it was mental health, and I was basically going to be some type of a committee amendment or some sort.
Yeah.
But as it's being, in re-refer, you can just bring that up
Right.
again. It's not a really big technical thing other than a big financial change, but at the same point, it's still not ready. So,
Yeah.
But with that change, it will change the direct, it'll change the fiscal note too.
right.
It'll hone it, it'll skim it down to where it needs to be.
Right.
All right.
All right. Any further discussion on re-refer? All those in favor say aye.
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 Opposed?
Consent?
Consent. Senator Avard moves consent. I'll second that. All those in favor say aye.
Aye.
Opposed?
Do you wanna have- How do
Um,
you want to take that?
Senator Prentice, do you want to take that out? That
You
was your
bet.
motion.
Yes, Chair, I will.
Okay. Thank you.
Probably you bet is not the most appropriate response. So yes, I'd be
Yeah.
happy to, thank you.
That's all right. We've got 2 minutes before our first hearing. Okay, let's, we can
And
do
My
that.
bill's the first hearing, I think.
243, relative to the Child Care Scholarship Programs.
Motion ought to pass for discussion.
Second,
All right, ought to pass.
there's an amendment.
Discussion.
So I have here that it's going to be approximately a $300,000 fiscal note.
E71, yep.
Mhm.
I would say, what did we do? Ought to pass?
Mm-hmm.
'Cause this is going to go to finance.
Yeah.
What is it, over 100K he requires to go to finance? Or
Yeah.
10,000?
100.
So it's gonna go to finance.
Yeah.
So, I think we should just move this over to finance. We're gonna be here till July. Huh? What was that? Oh, yeah.
Oh.
So this amendment is requiring a report. Other than Senator Rishardi, did HHS put this together?
I'm actually looking at some notes here, and it looks like this was based on some DHHS comments.
Spending of the program.
November 1 start time. Pilot would not commence if there is a wait list.
Yeah.
It requires federal approval, subject to federal approval. Yes, please do.
Kate Lippman, Policy Director for the majority in the Senate. The top part, I can't speak to, but I know when this, because they said they wouldn't have time with their rules to do it by, I think the original bill said May 2026, and this changes it to November 1st, 2026, which was their request. So as far as I know, their concerns have been addressed with this amendment. The rest of it I can't speak to, but it came from the sponsor. I assume she worked with the people who asked her to do this bill. So
I move the amendment.
Second.
Senator Avard moves Amendment 0616S. Senator Birdsell seconds it. Any further discussion on the amendment? All those in favor say aye.
Aye.
Opposed?
Move ought to pass as amended.
Second.
The motion is ought to pass as amended. All those in favor say aye.
Aye.
Opposed?
Consent.
Senator Avard moves consent. Senator Birdsell seconds that. All those in favor say aye.
Aye.
Opposed?
We'll take it out.
And Senator Birdsell will take that out.
So do you need a motion to move out of exec?
Let's do 244 and then
244.
then we'll have our hearings. So 244. Okay.
There is an amendment on this one.
Yep. I'll move on to pass on Senate Bill 244.
Second for discussion.
So this bill started out as a pretty significant bill. I do have an amendment that I would like to speak to. So I'll move Amendment 0630S.
Second.
Oh no, I'll have to flip an arm wrestle. Senator Avard seconded that.
All right, I'll give it to him.
So Senate Bill, this amendment that we've got, did you want to speak to that as well, Kate? I will speak to it. If I miss something, let me know. So what we did is, I met with the prime sponsor on this. As we know, this was a pretty significant bill, a lot of good policy positions in there. I met with the prime sponsor and recognized the fact that there were a lot of good policy aspects in this, but the size of the bill, I just was concerned that it wouldn't go anywhere, given the budgetary constraints that we had. So we sat down, we worked through the bill. I was able to take out her priorities when she drafted the bill. And just in a nutshell, it really emphasizes recruitment of primary care providers, particularly in our rural communities. It also provided resources to the Bi-State Primary Care Association, which in addition to the rural health primary care support, this will also add to the workforce development, recruitment, retention, support nurse preceptors, mentoring programs, and also some loan repayment opportunities. This is also, there was, as you recall, in the initial bill, there was a broad increase in Medicaid reimbursement rates. In speaking with the primary sponsor, we were able to kind of pare that down a little bit. One of the areas that we did do is increase reimbursements for the opioid treatment providers. It came to light that they hadn't had an increase in reimbursements for opioid treatment providers in 10 plus years on that. And of course, as we know, that whole area of our world has changed dramatically over the last 10 years. They initially came in and asked for the Medicare rate. We were about half of the Medicare rate. What this amendment will do is we'll bring it up more towards our neighbors, Massachusetts and Maine, which is about half of that. So that's what we have. That's what did I miss anything?
Did they have a fiscal note on the amendment?
We do have a fiscal note on the amendment. I think Kate can speak to that.
So the original, well, there's an official one, but in terms of adding up the numbers, the original bill, I believe, was over 60 million, and this will bring it down to about 8.
Oh.
And the part he was just talking about with the opioid, providers reimbursement, that's gonna be the new it's on the amendment, section 5. Section 5 used to be longer, and I can, if you want, I can read into the record what parts were taken out if that's helpful, but it's up to you.
Sure, you can do that.
What?
Read into the record what parts were taken out.
Sure.
Okay, so we took out section 4 Roman 3, section 4 Roman 8, section 4 Roman 11, section 4 Roman 12, section 3 Roman 2b, and then we took out all of section 5 except for section 5.3 Roman 3, and changed that number from 2.6 million a year to 2 million a year.
Any questions? Any further discussion? So I'm going to call the vote on amendment 0630S.
Move on to pass. Do we need that?
Second.
We have,
Okay.
yep. So we've got a motion. So all those in favor say aye.
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 Opposed? So
Move on to pass as amended.
all those in favor say aye.
Aye.
Aye. Opposed? All
Do I
right.
need a
five-
second on that?
Do you want Pat to take it?
Yeah, we can, Pat, would you like to take this one out?
Sure.
All right.
Who seconded it?
I did. Consent. Probably should move, I don't have a motion for consent.
So moved.
All right, I'll second, and Senator Bertzel seconds that. All those in favor say aye.
Aye.
Aye. Opposed? All right, and Senator Long will take that one out.
Too much.
On to finance.
Good job, Senator Long. All right. You need the motion to move out of it?
Yeah, let's move out of executive session.
So moved.
Seconded.
All those in favor say aye.
Aye.
So with that, we will open the hearing on Senate Bill 248 and I think 251. We're going to Senate Bill 251. The chair is going to call the prime sponsor, Senator Prentice, establishing a commission to study the delivery of public health services through regional public health networks and continued development of coordinated responses to public health incidents and emergencies in New Hampshire. We'll open the hearing.
First order of business is
Study.
we've got to replace this chair.
Yes,
Thank you. Well, that's it.
we should go put that in one of the other rooms.
Good morning for the record. Good morning, Chair Rocheford, members of Senate Health and Human Services. For the record, my name is Sue Prentice, State Senator from District 5, representing 15 wonderful communities of the Greater Upper Valley, Sullivan County, and one in Merrimack County, the beautiful town of New London. I am here before you today with Senate Bill 251, asking to reestablish the commission to study the delivery of the public health services through our regional public health networks. And the development of continued coordinated responses to public health incidents and emergencies in New Hampshire. So very briefly, this is something that when I first came to the Senate, I started working on, and here we are. We're moving into year number 5, but we've only as a group had a full probably year of working on this. And why I'm asking to reestablish it, because it was going to expire. We did our report. But as you can probably see from not only the legislation, but if you've had an opportunity to look at the report that was submitted to the governor, there are 13 regional public health networks in this state. We only have 2 full-time public health departments in the state, in Manchester and in Nashville. We have a part-time public health network, but largely throughout the state, how public health is assessed and the needs are responded to. And we did see this response really highlighted during the pandemic is through these regional public health networks. And they are delivering public health through a system without a sustainable, robust, funding stream. But before we can even get to that, we had to really work to understand with 13 different public health networks and all of the departments that they intersected with, as well as the Department of Health and Human Services. During this process, they launched an independent but related assessment to complement the work, which we didn't actually get into our hands until the last maybe 3 months before we were going to hit, 4 months before we were going to hit that November deadline. Let me make it clear from the outset that we worked very closely with DHHS. That's not the problem. The problem is the size and scope of this. We saw over 20 different presenters during our monthly meetings. People from other states, other systems, former public health directors. I don't know if any of you remember Dr. Jose Montero came and met with us. I mean, we looked at the historical setup, how we got to where we were, but at the end of the day, we don't have an infrastructure for public health that's set up that is sustainable that is sustainable as is throughout the state. There are 2 sources of funding that come, no general funds are involved in this. There are grant funds that are involved in this through public health, and they limit scope. So what these public health networks have to do is find other sources from other grant related projects so they can keep doing their public health work and do work that is associated with that all at the same time. It is not a way to run a statewide public health department, and we never may have one in that framework. The regional public health networks, they actually do work because they consider the local needs and what public health crisis, either issue or crisis is percolating in that area. But it turned out to be a huge project, and we're just simply not done. So again, we had 13 regional public health networks represented on this, representatives from different parts of state government. We interviewed over 20 people, came and presented on, their perspectives, specific items that we asked them to come and talk with us about. Again, the department did a companion report and a study at the same time but we didn't get that into our hands till late in the process. So being able to adequately cross compare that. This isn't a criticism. It's just a reality. Was, you know, we needed the time to crosswalk our recommendations, their recommendations, and what's going to be best for the state. And I can't guarantee you that at the end of the day, I can't guarantee you what we will end up with, but I think it's important for us to note, again, that this is being done in 13 different parts of the state, but with all one collaborated mission without a long-term plan for sustainable funding. And it requires a deeper, well, it requires the job needs to be finished. So that's basically what I'm asking you for here. We have a basic series of recommendations that we made to the governor, to the Senate president, to the Speaker of the House. But the number one recommendation was that we need to continue. And I'll read you the last line, the very short paragraph, and I think that will sum this up. The commission has worked. And they did. Volunteer members traveled from throughout the state. Some people zoomed in, but most times, we saw the North Country. Senator Rochford, Whitefield, your Regional Public Health Network folks from Whitefield were there. Senator Birdsall, always. Senator Avar, Bobby Bagley from the Nashua area, and those related to her were involved in this. We saw they came every Friday for months, but not done. So the commission worked diligently to understand the variances in size, capabilities, governance, and funding of the current public health systems. In August and September of 2024, so as we're coming to the close of this, the commission reviewed this CNA report, the gap analysis that was presented by the staff at the Department of Health and Human Services, and we met finally, and it was a really great meeting with the leadership of Health and Human Services. The group completed individually a scoring tool so that they could look at their own local assessment and governance capabilities, and taking the CNA, the time with leadership, all of the history that we have in order for the commission to fully and properly explore its primary recommendations, along with late but essential conversations with Health and Human Services leadership. The group agreed we need more time and respectfully request an extension. So the extension in this is actually the reestablishment of it, because it was going to expire under the old statute. And so I left that, let it expire, and came back and asked to do more. Great volunteers, great networks, doing great work, but we just need to finish our job. And everyone is committed to continuing on and being at the table. So that, I have Stephanie Locke here with me from the department. Stephanie's also a paramedic and someone that I've had the opportunity to work with over the years, and she leads this program at the Department of Health and Human Services. So it's been great to have her alongside as we have worked through this. So that's all I have to say. I'm happy to take any questions or refer them to my friend and colleague Stephanie. Thank you.
Are there any questions? Seeing none, thank you very much.
Thank you, Chair Rochford.
I know you mentioned Stephanie. I don't have her signed up to speak, but I don't know if you. Oh, you want to speak? All right, absolutely, yes.
Grab that chair over there.
Bring that chair
You're
over.
bringing that over next to you for both of you, if you're gonna both sit up there.
Abby, yeah, I can sit, sure.
Good morning. My name is Abby Rogers. I'm the legislative liaison for the Division of Public Health Services.
Good morning. Thank you for the opportunity. I'm Stephanie Locke. I serve as the Bureau Chief for the Department of Health and Human Services Bureau of Emergency Preparedness, Response, and Recovery, which is the bureau that oversees the 13 regional public health network programs. Can I jump in? Yeah. So thank you for the opportunity to meet with you all today, and thank you, Senator Prentice, for this as well. The department was happy to serve as a resource to Senator Prentice and the commission that was established under the previous legislation. In reviewing the current legislation that's being proposed by Senator Prentice, the scope of work really seems very similar. I think Senator Prentice did an amazing job identifying the diversity of services the regional public health networks perform perform based on the needs within their communities. And so some of those areas are emergency preparedness and response, both large scale, such as seen during the COVID-19 pandemic, but they continue to serve in that capacity on a daily basis on smaller scale. Outbreak responses as well. They serve as a resource for information sharing with their partner agencies, their healthcare, their emergency management, and other partner agencies within their communities. They are tied to the substance misuse prevention work in creating access and opportunities to those services. And they also work on community health improvement plan, which is based on the community health assessment that they lead. That's in collaboration with the local healthcare systems who also perform their own community health assessment. And so you can see how the regional public health networks serve as a real liaison and champion of their communities. And this commission is dedicated to exploring that and looking for sustainable ways to continue that program. And the department is happy to continue to serve as a resource to Senator Prentice and the commission. So I'm happy to answer any specific questions, but just wanted to share that perspective and support that we've been able to provide Senator Prentice. And thank you, Senator Prentice, for your support of public health in general, and specifically for the 13 regional public health networks.
Thank you. Any questions? I have a question. So with the public health networks, you listed a number of the things that you do, and this is from my knowledge. That probably would give me a little better background. Does the public health networks investigate things like potential cancer clusters, or you talk about outbreaks? I mean, that's infectious disease, but if there was a potential cancer or concern about a potential cancer cluster, would that fall under your purview?
So we would work with the regional public health networks to get information from the community levels, though they don't perform the investigations themselves as it relates to cancer outbreaks, but they serve as a resource to community partners, both in terms of sharing information from the department to the community partners. And I think just as important, serving as a resource for us to hear the feedback from our community partners. So they're part of the conversation, though they don't lead the investigation themselves independently.
So the community partners would contact you, and that's how the investigation would carry out?
Correct. And then we utilize the regional public health networks as a mechanism to provide either more detailed information from the department to our community partners, and again, to hear from our community partners what their concerns are and what's specific to their region, so that the department has that community level perspective and not just that high level global perspective across the entire state.
So what role would the community partners have in, let's say, investigating a cancer cluster?
So I think it's tied to, for instance, health officers play a role in that. Those are independent of the regional public health networks, but they work alongside our regional public health networks. And so it's connecting the right partners, the right agency, given the outbreak or cluster that's being investigated, to make sure that we have that global perspective and making sure that the right partners have the information that they need.
And there's 13 public health networks. Does each community have a community liaison, or would, if there was a concern, we would go to the local regional public health network and you would assist with that?
Sure. So there's one liaison from each regional public health network. So every community within New Hampshire has representation through their regional public health network, and each municipality also has a local health officer that the communities can go through. So it's important that the local health officers and the regional public health networks work together to be able to create that access point and communication mechanism from the state to our community partners.
Very good. Thank you. Any further questions? Senator Prentice?
Not a question, just I want to provide a just further clarification. When these were first established, I mean, it came years ago with the Turning Point grant, but we really saw the regional public health networks built out in the 2000s through a series of grants that came to this state. And one of the things, and this is back when I worked in state government, that we did was looked at hospital service areas, emergency medical service regions, all of the different like fire mutual aid districts, whatever there were for regional networks that are already established. And I remember going in with, remember those old overhead projectors with the transparencies, and laying them over each other so that we could align communities of interests within geographical areas that were already working together in that way. So every town or city had a voice into that network, but working with one person who represents them, you know, sets up the contract and runs the day-to-day business.
Okay.
Does that make sense?
Yes, it does. Yep.
Okay.
Yep.
Thank you
Great.
for the opportunity.
Just one question, if I may.
Yes, Senator Avard.
Thank you. So Turning Point was the original point of grant money. This is all funded through grant money?
Correct. It's still funded through federal grant money from several of our federal partner agencies.
Are there any strings attached to the grants?
So each grant has a scope of services we're required to meet, which is why we're very careful in analyzing each grant opportunity to make sure it aligns with the work that the public health networks are doing. And I think that's what Senator Prentice was referring to in terms of identifying sustainable funding. I'll say the federal funding has been level funded for more than 10 years. And as you're aware, the costs have increased. And so we're finding that there is a delta of what they need to be able to perform their services, but we've been able to align the scope of their services based on the community needs and in alignment with the federal funding requirements.
Thank you. That's it.
All right. Any further questions? Thank you very much.
Thank you.
So that's all I have. Does anyone else like to speak on Senate Bill 251? With that, I'll close the hearing.
You want to take it or?
We've got one more. Do you mind if we exec this now? No. All right.
Move
So-
into exec.
Second, all those in favor say aye.
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 So any
on
executive
to-
session
Move on to pass move on to pass.
ought to pass. We've got a motion from Senator Avard, ought to pass, seconded by Senator Birdsell. Any further discussion? All those in favor say aye.
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 Opposed?
Consent.
Senator Avard moves consent.
Second.
Senator Prentice seconds. Ready? All those in favor say aye.
Aye.
Opposed? Senator Prentice, would you like to take this one out?
I'd be happy to. Thank you.
All
Motion to
right.
move out of exec.
Second.
Motion to move out of executive session. All those in favor say aye.
Aye.
Aye. Opposed? No. All right.
Please.
All right. Actually, I'm gonna give that to you.
Is it hot in here? Is it me?
It's hot in here. It was hot in here yesterday too. If you can crack a window right over there. Senator Birdsell might not like it when she gets back, but that'll give us. Well, it's either that or one over there. Oh, Senator Avard's got it done. All right. We had to do that yesterday too.
All right. Are you all set, Sophie? All right. We're gonna open the hearing on Senate Bill 248, establishing a committee to study palliative and hospice care in New Hampshire. Chair recognizes Senator Birdsell, the prime sponsor.
Thank you, Mr. Chair. Thank you, committee. For the record, my name is Regina Birdsell, State Senator for District 19, which encompasses the towns of Derry, Hampstead, and Windham. And I'm the prime sponsor of Senate Bill 248. And basically, this establishes a committee to study the palliative and hospice care in New Hampshire. I know that I would like to ask that we don't exec this today, because I know that the medical assistance in dying bill passed committee last week and is on the floor, I think, this week, or I believe. So what I'd like to do is if there's any pieces in that bill that we can merge into this bill, I'd appreciate it if we wait until after that, if that bill passes. If it doesn't, that's fine too. But basically, like I said, it's a committee to study the palliative and hospice care, to see if there's anything that we can do to kind of help our residents that are in these conditions and make it easier for them to move forward.
Great. Thank you. Any questions? No, thank you very much. I'm going to call Colin McNabb.
Let me know if that's too much.
Good morning, Mr. Chair and members of the committee. Thank you for allowing me to testify in favor of Senate Bill 248 on establishing a committee to study palliative and hospice care in New Hampshire. My name is Colin McNabb, and I'm the Director of Mission, Integration, and Spiritual Care at St. Joseph Hospital in Nashua. Palliative and hospice care is an integral part of our healthcare system and has provided much comfort to our patients with serious illness to limit their suffering. Further, our palliative and hospice care services provide support to our patients' families and to the patients themselves. In his second letter to the Corinthians, St. Paul writes, God is our merciful Father and the source of all comfort. He comforts us in our troubles so that we may comfort others. When they are troubled, we will be able to give them the same comfort God has given us. Morally, we as a society have a responsibility to care for those who are suffering and do whatever possible to keep their pain at a minimum until it is their time to go home to God. But even taking away faith, it is our duty as human beings to comfort the afflicted as well as supporting comfort to their families. Barriers to palliative and hospice care include fear, lack of understanding, and financial limitations. Further, resources and cultural and spiritual practices also play a role in limiting access to palliative and hospice care. That being said, the main reason I came here today to testify is that our hospital is ready and willing to assist this proposed study committee in any way so that all residents of New Hampshire have access to this vital service.
Thank you very much. Are there any questions? Thank you.
Thank you very much.
Kellyanne Totten. Oh, you turn your microphone on there. Thank you.
I'm going to need it today.
Yeah.
Good morning. Thank you, Mr. Chairman and Senators. My name is Kellyanne Totten. I'm the CEO with Granite State Home Health and Hospice, the affiliate for, get ready, Home Care Hospice Palliative Care Alliance of New Hampshire. We represent nearly 50 members providing home care and hospice services throughout the state of New Hampshire. We remain neutral on this bill and are speaking today to just make it known that we are supportive of increasing education and awareness about palliative care services and hospice services, and would like to be included going forward as experts on the subject matter, and certainly have the opportunity to provide our member organizations, palliative care medical providers, as well as hospice providers, should this come together in the future. It is a service, both palliative and hospice, that is available throughout the state.
Any questions? Senator Birdsell.
So, I'm sorry, Kelly?
Kellyanne, yeah.
Kellyanne. So in the duties here, it says the scope of the committee's review shall include but not limited to palliative and hospice care for people with disabilities, recipients, care services, people with dementia. Should we also add in education?
I think in conversations that I had with others, it sounded like there was a lack of knowledge or awareness about how to access the benefit.
Okay,
And so
all right.
certainly, thank you.
Just along that same I did hospice work for years, and one of the challenges that we ran into was on an education aspect, and it wasn't so much how to get the services, but finding providers who could deliver palliative care services that are using, whether it be best practices, whether it be evidence-based. Are you finding that the education level of the providers, both nursing and physicians, has increased over time, or is that a barrier to access as well, of provider education?
It has increased over time, and there's a theme of I started in the fall, and we had a hospice and palliative care conference with people from all over the state, and that was part of a robust discussion around benchmarks and quality of care. And in the state of New Hampshire, I do think we are in a place of strength with the quality of care provided and available for hospice and for palliative care. Certainly from a workforce perspective, it is a challenge, just as it is within the hospitals and in our home care sector as well. But the quality of care and continuing education requirements through their regulations as well as their quality programs is strong. And as the Alliance, part of our role is to provide that ongoing education as well.
Great. And if I may follow up,
Yeah.
I'm sorry, you're having trouble
that's
today.
okay. It's
I
all
was
right.
there about 3 weeks ago. I know exactly what you're going through. So, obviously your network is the southern part of the state, correct? Are you finding?
full state.
Oh, it is. Okay. So you're
Yes.
finding the education level and the access to resources as far as educational resources is adequate, or at least growing throughout
Growing.
the state, in all parts of the state.
Correct.
All right, very good. I
Nope,
won't
that's
ask any
okay.
more questions. Any more questions? All right, you're free to go.
Thank you.
Thank you. Bob Dunn.
Good morning, Mr. Chair, members of the committee. I'm Bob Dunn, the Director of Public Policy for the Roman Catholic Diocese of Manchester. And I'm here today on behalf of Bishop Peter Labashi to register our strong support for this bill. Pope Francis sent a message to an international symposium on palliative care just last May that was taking place up in Toronto. And he said a couple of things in that message that I think will resonate with people regardless of their faith background. And he said that palliative care is, above all, a concrete sign of closeness and solidarity with our brothers and sisters who are suffering. And he called it a genuine form of compassion, for it responds to suffering, whether physical, emotional, psychological, or spiritual, by affirming the fundamental and inviolable dignity of every person, especially the dying. And one thing that he added, and I think this is really a critical point, is that he spoke to the folks who provide these services. And he said to them that your service is important, I would even say essential, in helping the sick and dying realize that they are not isolated or alone, and that their lives are not a burden. I would just say that over the last year and a half, I lost 2 close family members, and I cannot imagine what that experience would have been like without the assistance of the hospice care providers. It was only, I think, through going through that I learned just what it was that they do and how important it is, the services that they provide. And that was true for us with strong family support, friend support, but in an era where those support networks of families and friends are probably diminishing to some degree, the services that hospice care providers give to people are absolutely indispensable. And I think this study will be useful in serving as a center of gravity in trying to make this information available to people and to figure out what is the best way that we can bolster access to these services. Thank you.
Thank you. Any questions? Thank you very much. Let's see, Lisa Bowden.
Good morning.
Good morning.
My printer decided to have a tantrum this morning. Appreciate your patience with my laptop.
It needed a day off.
Yes, it did. Thank you. I want to start with thanking you for your commitment to public service. I'm not sure that we say that enough out loud at these hearings. For the record, my name is Lisa Bodwin, Strategies for Disability Equity. I offer that SB 248 is a necessary and overdue step in understanding the gaps in end-of-life care and ensuring that Granite Staters, regardless of their background, socioeconomic status, or disability, have access to quality, compassionate, and equal access to care at the end of life. In spite of the palliative care workforce's unyielding commitment to professional excellence in care delivery, We all know that New Hampshire's healthcare system is stretched thin and that disparities in access to palliative and hospice care are significant, although we don't have actual data. We know that pain management and palliative care education are inadequate. We know that funding is insufficient and that many of our most vulnerable residents, people with disabilities, those with limited financial resources, and those who are historically marginalized and underserved, are left with few good options when facing serious illness. The days of intractable pain should be behind us. The medical technology is available. Yet too many people still suffer unnecessarily because our healthcare system lacks the proper training, resources, and funding to ensure dignified and pain-free end-of-life care. This study commission is essential because it will allow the state to take a comprehensive look at gaps from multiple perspectives. Healthcare providers, patients, caregivers, and policymakers can all contribute so that we can craft informed and effective solution to addressing the gaps. It will help us to understand the barriers to palliative and hospice care and identify the systemic reforms needed to improve quality and accessibility. I offer that the New Hampshire legislature has an obligation to prioritize the needs of all of its residents, particularly those who are vulnerable. You all know that I usually sit before you advocating on behalf of the vulnerable. This study commission is a responsible, measured step to ensure that public policy decisions about end-of-life care are rooted in a full understanding of the real gaps and challenges that Granite Staters face. I urge you to vote to pass on SB 248 and commit to securing accurate information upon which to build and strengthen a healthcare system that provides dignity, access, and comfort for all at the end of life.
Thank you. Are there any questions? Thank you very much. Mark Golinek.
It's been pronounced so many ways. It doesn't
If I could read the handwriting, I would have pronounced it right. I know that name, so I should know
Not
better.
a problem
I
at all.
should be able to read that, but Mark Gilmet. All right.
Good
Thank
morning, members of the committee. Thanks for this opportunity to testify in favor of SB 248. My name is Mark Gomet. I am the Vice President of Catholic Mission Identity and have been at CMC for 12 years. In that role, I'm responsible for our ethics consults as well as visiting our patients as chaplains, as well as being on our palliative care team over those years. And as already been mentioned, there is a lot of misunderstanding about, in particular, palliative care. As you all know, palliative care is for individuals with chronic illness. They can live lives 2, 3, 4, 5 years. They have things like congestive heart failure, COPD, diabetes. And really, the key with palliative care is to symptom management, as well as then to allow them to live the quality of life that they want, for example, so that they have enough energy to be able to go to Sunday dinners with their family, get together with friends. And sadly, a lot of people will equate palliative care with hospice care. And so when providers mention palliative care, many times it's no, because they think their loved one is dying or they are dying. And so this committee could do a great job of providing education to the citizens of New Hampshire. Another challenge is when a patient may receive great palliative care in the hospital, but there are fewer palliative care programs in our state, in part because of low reimbursement rate. And the sad part is that palliative care allows patients not to be back in the hospital and thus reduce the cost of medical care. So certainly this, and then with hospice care, certainly we all know the great value of hospice care and allowing patients to die at home, surrounded by their families instead of a sterile hospital room. And so I look forward to the work that this committee could do in this study, Bill. And thanks so much for your time.
Great. Thank you. Any questions? Thank you very much. Thanks. Ellen Edgerly. Good morning.
Good morning. Good morning, Mr. Chair and committee members. My name is Ellen Edgerly. I am community organizer for the Brain Injury Association of New Hampshire. I have some written testimony from Steve Wade, the executive director. He's traveling, he's in DC today, so he unfortunately was not able to attend today. I promise to be brief, and I'm nervous. I haven't testified in like 5 years, so excuse me.
We're nervous too.
We're easy here. We're easy
I
here.
like that. Because brain injury is a life chronic condition, nearly all survivors of brain injury require access to Medicaid for their long-term care. Unfortunately, Medicaid, unlike Medicare, does not provide good access to palliative care. Access to palliative care is often critical for brain injury survivors to remain in home and community-based settings instead of transitioning to nursing care. It can certainly delay the transition by enabling brain injury survivors to remain at home and in the community. It is therefore important for the state to study access to palliative care for brain injury survivors on Medicaid from both the state fiscal perspective and enhanced quality of life for survivors. People with brain injuries often have unique issues, challenges, and circumstances that make it much more difficult for themselves. Palliative care aims to provide comfort and improve quality of life for people and their family, and to help people to live and cope with the life they have left. It can be provided within people's homes. On a personal note, back in 1992, one of my 4 children, Sarah, was involved in an accident. As a result, she sustained a brain injury, became a quadriplegic with significant health issues. These supports could have been helpful to me at that time, but granted that it was back in 1992, I'm not too sure. I'm sure we've come a long ways. This study would be helpful in clarifying what New Hampshire Medicaid palliative care services can offer. And then on a side note, I tried to do some research the past week, and I actually talked to a couple of case managers, and I got 2 different reports where I was told by one that palliative care was not covered through Medicaid, and another that it was somewhat. So I think that this study would be really valuable to the citizens. Thank you.
Thank you. Any questions? Thank you very much. Is there anyone else that would like to speak on Senate Bill 248? With that, I'm going to close the hearing. Yeah, let me make a quick note here. I have a motion to move into exec. Do I have a second? Senator Avard seconds. All those in favor to move in executive session, say aye.
Aye.
Aye. All right, I have. We did 124, right? That was 5 OTPA. OTPA 5-0. Senate Bill 245.
That is me.
That's you.
All right, I have an amendment. So I'm gonna make a motion ought to pass.
A second discussion.
Okay, so this is our Emergency Medical Services No Surprise Billing and System Stabilization Act, and this is I'm gonna pass this out. We had still working on some clarification from OLS, but here is what I'm proposing as a committee amendment in response to comments that were made or concerns that were raised at the hearing. And I will walk you through this. Everyone have a copy with Senator Birdsall? Yeah, okay, you're being included. So, first, one of the concerns that was raised is that by Anthem is that this did not specifically prohibit balance billing, but she didn't feel that it expressly prohibited balance billing, but in section 1, item A, and in item B, item A says the payment, the payment shall be considered in full when it comes from the insurance carrier. And item B, the non-participating ambulance service provider is prohibited from billing the covered individual for any additional amount for the ambulance service. So unless you want it to require further, I think that and I think I know that covers the prohibition on balance billing. Because remember, we're working to prohibit balance billing, but to raise and stabilize reimbursement rates during emergencies and non-emergency transfers for ambulance services that are currently not in network. So that was number one. Number two, there was a concern raised about capping the copay at $100 or any cost sharing. So it's not that I don't think that that's important, but when the federal law, if Congress passes this federally, that will come into play there. And I decided to take that out so we could just be solely drawn towards the primary message, which is these the non-participating providers, when their beneficiaries need an ambulance during an emergency or an emergency transfer, that they are not balance billed and that the ambulance service can be fairly and adequately reimbursed as we have outlined in here. Number three, there was a concern that was raised about there's already a clean claims statute, part of the statute, and that I had language in here that did not comport with New Hampshire. So New Hampshire statute. So section 2, item 5, it points, and I did work with the Department of Insurance on this. It points to RSA 420J8A, and those are the prompt payment clean claims. So we're pointing right to the statute that already exists. So that's a change that I made. And last but not least, in number 6, there was a concern in how I used the ERISA. So what I did, again with the guidance of the Department of Insurance, was took out ERISA from here and just put insurance plans subject to the jurisdiction of the commissioner, which according to the Department of Insurance would cover that. So that I've responded to the concerns that were brought up during the hearing. Again, this is no surprise, prohibit balance billing, but to bring a fair and adequate reimbursement rate for ambulance services that are non-participating providers when there is a 911 call or a unscheduled transfer for somebody that say has an emergency and needs to go. Well, Siri's recording everything I'm saying. Okay, needs to go to Boston or to Dartmouth or to, maybe over even to Vermont or to Maine for care that they can't receive in their local community and it's an emergency. They shouldn't have to worry about whether that will be covered. So when we consider fair and adequate reimbursement here is the town set rates, town or community set rates, which again are established in public, or 325% of Medicare, which I just want to remind everybody, out of 12 states that have already passed this kind of legislation, 7 of them have set a cap one is at 400%, 6 are at 325%, because those states have tested this and feel that it is enough. It's not perfect for everybody, but it's better than where we are at right now. And that is, I want to remind folks that ambulance services are closing. And we just had one in Senator Rochford's district close, I think last week, in the North Country, that handles a majority of the transfers out of AVH. So we've got to take some kind of action. We had a Senate position on this last year. I believe I've cleaned this up to hopefully to everyone's liking or understanding, and I'd stop at that. Okay.
Was there a fiscal note?
Is there a fiscal note with that?
It doesn't say really.
This is not an FN.
Yeah, it is an FN. Yep.
It is an FN?
The original bill was.
The original.
But I think it's an FN only because
They're so local. There could be a little cost.
the bill mandates that managed care health insurance plans cover emergency ground ambulance, requiring health carriers to pay non-participating ambulance providers, either set right at local governments or 325% of the Medicare rate. So
Just being courtesy.
I know. I love that. It's okay.
Senator, I don't know if Senator, you have some thoughts on this?
It's the first time I'm taking a look at it. It'll take a little while to digest it. That's all. So
Thank you for asking. I think, Senator, you've done a lot of homework on this. I'm a lot more comfortable with it. But, what are your thoughts?
I'm gonna support it.
Yeah, I'm going to support it.
First of all, we did have a Senate position last year supporting it, so.
Is there a number on the amendment?
No, because this is a committee amendment. I sent it over to OLS. What they sent back had two sections in it that I needed to make sure. There were eliminated two sections that I need to make sure are in the bill, so I think there might have been a miscommunication. So I'm presenting this as a committee amendment with the detail, and then we'll get the official.
Is it as a replace all? How do you?
It's so what I think happened is these are very surgical, like they're very specific asks. And so they didn't, I want to make sure that like the first part of section 2 wasn't in what came back from OLS. And that needs to be in that needs to be in there. So did they just take it out because this is replacing those parts of it? But the introduction to the amendment that came from OLS didn't indicate that. So that's my worry. And that's why I wanted to present it this way.
So do you need a walk down as to how, or you have it all in front of you? Probably should walk it down then. Yeah. Can you walk us through how it changes from line to line?
You bet I can. And my first item that I brought up on prohibition of balance billing was just a commentary, a clarification, so that does not need to change.
On page,
So we're gonna go to page, well, this is page.
go ahead,
Is
the
there
original,
nine up?
and I have
This
the
is page
amendment.
1.
Okay, yep.
Okay, and you're gonna go to section 1A. So we're gonna go specifically to lines 18 and 19. It lines out, provided that no covered individual shall have a co-payment for ground ambulance service provided that exceeds $100. So it just takes that out. And I'll hand this right over to you, Sophie, with my notes on it.
So
Okay.
this is basically your original bill with the changes in it.
Correct.
Okay, got it.
I wasn't 100% secure with what came back from OLS.
Got it.
So that is why I wanted to approach it this way
Okay.
today. So then next is going to be same section, item B, 20 lines 23 and 24. Once again, lining out, starting on 23, provided that no covered individual shall have a co-payment for ground emergency ambulance service provider that exceeds $100. We're just taking the cost share and the copay caps off. Okay, so then let's go to page 2. Section 5, or Roman numeral 5, line 6. And this now says, and I'll start at 5 and read it through to 6. A health carrier shall reimburse a non-participating ground emergency ambulance provider in accordance with RSA 420-J:8-A, which are prompt payment requirements. So that covers the clean points rate to Department of Insurance's statute on this. And it probably shouldn't say R, it should say the prompt payment requirements. And I'll hand this to you when I'm done. And lastly, 5, 6, starting on line 7, a health carrier shall clearly indicate on all payments explanation of benefits whether the claim relates to an insurance plan subject to the jurisdiction of the commissioner. Ends on line 9.
On page 2?
Page 2, yes, page 2, 7 through 9.
So I move the committee amendment.
Second.
So any further discussion? Senator Avard moves the committee amendment. Senator Birdsell seconds. Any further discussion or questions? All those in favor say aye.
Aye.
Move on to pass as amended.
Second.
Bill ought to pass as amended. Senator Avard with Senator Birdsell seconds. All those in favor say aye.
Aye.
Opposed?
Consent.
Motion to consent.
Second.
Senator Prentice seconds that. All those in favor say aye.
Aye.
Opposed?
Thank you, everyone, for your patience. I just wanted to be sure.
All right, great.
Senator Prentice, take it out.
Oh, yes,
Oh, I'll
Senator
take it out.
Prentice,
You
yep.
bet. Oh, yes, I'd be happy to.
Right.
Good job.
I got one more. Last one on my list is Senate Bill 249.
I'll move on to pass.
On 249, what is 249?
Met dish.
49 is back dish.
About to pass?
Mm-hmm.
I'll second, because you said so.
For discussion.
Discussion.
I'm pushing this forward as is. I want to give the governor another week to work with the hospital association to try and get something together. Otherwise, we'll work on it
In finance.
in finance.
Senator Prentice.
Thank you, Chair Rocheford. And Senator Birdsell, I appreciate your work on this. I understand what you're trying to do. I can't support the motion, but I understand what you're trying to do and where we're ultimately trying to go. I'd just like to share a few things on why I can't support the motion. And we heard in the hearing, I mean, I have 3 hospitals in my district, and at least one of them came in, but we heard from St. Joe's, we heard from Dartmouth Health, and we also heard from a small community hospital that I actually used to run the ambulance service for, about how, as is, this would impact them. So we're talking about the 80% distribution totaling up to what could be $70 million tax on hospitals. I mean, we all know this, but just for clarity, and again, I want to move through this and get this done right. And we heard from Cottage, St. Joe's, and at least Dartmouth Health. Those are the 3 that I remember, and I referred to the hearing report because of after talking with Dartmouth Health about the precarious position that hospitals are already in, and that what we have to do to try to secure and stabilize that they are our safety net, they are our healthcare system, they are where people go, access to care you all know this has always been important to me. So we have to shore this up, and it would be as is, coming into this, and as is, it would be very difficult for them. I think we all know, but just it's worth mentioning that we have at least 2 court cases where the current setup under the medication enhancement tax has been considered unconstitutional, that the payments, hospitals have been making these agreements, but that is going to expire. So we put a lot at risk when that expires if we don't get this settled. And then lastly, I do refer to during the hearing, and I trust that Senator Birdsell has looked to this and will consider it in future conversations, the proposal that the Hospital Association brought forward, talking about, because there's an allowance for a higher assessment of the hospitals. Right now it's at 5.4. If we moved it up to 6%, then we could actually increase the revenue that would come in by 39 million, which would be a potential win-win solution. So I'm with you in spirit about what you're trying to do. I just wanted to get, given my time and background working with hospitals, I wanted to get this on the record. That's all.
And I get all of that, and I know that we have work to do on it, but I have to give the governor some more time. And if not, we'll take care of it.
Yes, we will. Okay, thank you, Senator Birdsell. All right, thank you, Chair Rochefort.
Any other comments? Okay, we've got a motion ought to pass. In a second. All those in favor say aye.
Aye.
All those opposed?
Aye.
Me.
So 3-2. Senator Birdsell will take it out. I'm assuming you don't want that on consent.
No,
What?
A consent?
Oh,
you can't do a
no,
consent.
can't.
it's
Oh,
one,
3-2,
two.
yeah.
Sorry. No, I don't want it on consent.
Is that the last one?
That's it.
Motion to move out of exec.
Second, all those in favor say aye.
Aye.
Opposed, so we will,
Do we have any House bills that are waiting for us? Oh, good.
wow. Okay, and I think we have what, 7 bills left?
We do?
We have 7 that have not been scheduled.
Okay.
Scheduled.
Oh. I thought we were done.
No,
Oh,
no,
yeah.
we're almost done.
We're not done.
We can bang out 7 in one day.
No.
No.
You don't like those all day ones? We're gonna close the hearing.
Yeah.
You don't like those all day ones?
I hear you.
Pull a little bit over this way.